What I'm going to do is start with definitions, talk about research cycle, what are the steps involved in conducting systematic reviews and meta-analysis, and then summarize. I will do it in a very non-mathematical fashion, so you don't have to fear about equations and things like that. We know we need reviews. Nobody can keep up with more than 20,000 journals per year and more than 2 million articles. So we need to separate the insignificant and unsound articles from the salient and crucial ones. And most importantly, we need summary of all these, which can guide us in taking patient care decisions. There are traditionally, or less, two ways to do this review. One is traditional, also called narrative review, and the other is systematic. Traditional is usually broad, starts with epidemiology, etiology, pathology, pharmacology, and so on, and has typically no method section. So you can't reproduce because we don't know how the review has been done. So very strictly speaking, it doesn't meet the criteria of reproducibility as it is in science. But in contrast to this, a systematic review is a research summary. So it provides summary that addresses on a focused clinical question. So it's not as broad as traditional, in a structured and reproducible manner. So often, this systematic review contains a quantitative part, which is called meta-analysis. And in meta-analysis, we statistically aggregate results from 2 or more studies if we think it's appropriate to do, and we'll see how we check the appropriateness. So, if I can tell you our own journey of surgery in intracerebral hemorrhage, when I was in McMaster, I wrote a thesis, and part of it was systematic review of role of surgery in intracerebral hemorrhage in 1997, and a trial followed that. And I must tell you, we had a lot of discussions based on this review with principal investigator Mendelo, and Stitch 1 trial, which of course was very well done. And following this, we did a meta-analysis, which is surgery for primary supratentorial intracerebral hemorrhage as Cochrane review. Also came in stroke as Cochrane corner. Following this, there was another trial, which was Stitch 2 trial, and in between a meta-analysis, which has been actually conducted with a subcomponent of our meta-analysis, which included only minimal invasive surgery. So as you can see, typically you start with systematic review, find the gaps in knowledge and also the summary of knowledge, which leads to research questions and research proposal, new data comes, and then you do again systematic review and meta-analysis. So this cycle is going on in so many fields, not only surgery in intracerebral hemorrhage, practically all the fields. So what do we do? Well, we basically do a scientific review of literature to generate and focus research questions. It has many advantages. It strengthens the research proposal, and there is a requirement by funding agencies, I will show you that. And it provides summary for framing guidelines and has impact on clinical practice. So one example is this Medical Research Council of UK. It says very clearly that applicants are encouraged to conduct a systematic review of the available evidence. When you put the proposal, you have to preferably put also a systematic review with it. Similarly, Canadian Institute of Health Research, it encourages all grant recipients not only to do the systematic review, but to publish the systematic review, which is submitted as a part of grant application. And one more example, which is about reporting a trial. Once the trial is done and you are reporting it, you know the famous Consort Guidelines, which says that in item 22, that either in discussion or in results, you have to preferably include a formal systematic review. So you can see that you start with review, you end with review, which is a very key aspect of research cycle. So what I tell my students is, we review to know what is known, to determine the certainty with which we know, and to find the gaps in knowledge. so you can do further studies. And there are two types now recognized about systematic review. One is called retrospective, when you do it on completed studies, and one is prospective, when you plan to do it on ongoing and future studies. And meta-analysis, which is usually compares two treatments, which is based on data of groups of patients, is called conventional meta-analysis. But when it is based on data of individual patients, it's called individual patient data meta-analysis. But when you compare multiple treatments, like interferons and glatiramer and fingolimod in multiple sclerosis, then it's called multiple treatment comparison meta-analysis. Now, a more, let's say, useful term is probably network meta-analysis. So these are the different types. Now, which studies can be subjected to systematic review or meta-analysis? All kinds of studies, whether it is diagnostic, prognostic, interventional, or even education studies. But I'm going to focus more on interventional studies during my talk. I often say that you have to remember 6 S to do a systematic review. First S is state. State the review question. Actually, you have to write a protocol which contains all of the components. Second is search comprehensively. Select with some eligibility criteria. Then scrutinize, which is mainly for risk of bias and also for similarity of results. Then synthesize, which is just like taking out average. And then summarize, which is summary of findings table. So Cochrane review goes through this typical process: state, search, select, scrutinize, synthesize, and summarize. Let's take each one very quickly. In the review question, you have to specify population, intervention, comparison, and outcome. Search comprehensively, which includes not only electronic databases, but also hand searching, asking experts, looking at conference announcements, contacting pharmaceutical companies, and also go to the registers. There are registers available, like stroke register is in Ottawa and Cochrane Library. So you have to really do a very comprehensive search and try to get both published as well as unpublished studies. Select with eligibility criteria. Now, eligibility criteria must specify the study design. Whether you want to do only on randomized controlled trials, or you want to do case control studies as well, cohort studies, what kind of studies you are going to include in the review. In typical intervention systematic review, only randomized controlled trials are included in study design as far as selection criteria is concerned. And also, population intervention, comparison, and outcome will form part of this when you become a little more specific about the criteria. So typically, you have to present a graph or a flow chart which starts with how many studies you found. We did a systematic review of mobile phones and incidence of brain tumor. Started with 159 studies, then excluded some for various reasons. Then you get the full papers, read it, then you may exclude some more because of duplicate reporting or whatever. Then get, say for example, in this case, 21 case control studies which we summarize. So you have to have a process of screening based on abstract and titles, and go on to full papers and find the final set of studies which you are going to review. Then coming to scrutinize, risk of bias. There are several biases, but mainly we focus in a randomized trial on selection bias, measurement bias, attrition bias, which is lost to follow-up, performance bias, which is physicians and patients sticking to the protocol, and confounding, particularly at baseline prognostic variables. And these are the main kinds of biases which we look at when we do Cochrane review. But in other kinds of studies, you have to have your own list of biases which you will go examine in those studies. Now let me give you a story which is about students' complaint, and I would like you to participate in this. Students' union in our place wrote to the dean, there has been a problem with the examination results. Some students who failed were actually good, and some students who passed were not good at all. Does it happen in your country? Sometimes happens, yes. So dean usually, as usual, appointed a committee to examine whether there is really a need to investigate this, and if so, then investigate the problem. Now let me give you overview of the examination. Written exam was full marks 100, practical full marks 100, Viva full marks 100, pass marks was 50% of the total. And the committee looked at the patterns of marks. So these are the 4 patterns in which most of the students fell. So some groups of students fell in this, some group of students in this, some group of students in this, and some group of students in this. So first, these groups all passed, these groups also all passed, these groups failed. Now tell me if you have any problem with any pattern. And I'm going to ask you each pattern. If you need time to look at it, look at the marks. Written marks here, then practical, then oral. Pattern 1. Does anybody have problem? Please raise your hand. No. Pattern 2. Does anybody have problem? Yeah. Anybody else? Yes. So pattern 2 is problematic. Pattern 3. Anybody has problem? No. Pattern 4. Pattern 4, a lot of people have problems. So pattern 2 and pattern 4 are problematic. And can anyone tell me why they are problematic? Yeah, so you think these groups of students got average 15 in written, 70 and 80 in practical and Viva, right? So what is the problem?
Heterogeneity.
Okay, so they didn't get similar marks, and here they all got similar marks, right? Any other person wants to say something? What about pattern 4? Written they got very good, but oral and written practical very low marks. You know, so when I ask students, many of you are not students anymore, they say these people were probably children of the professors. And in Egypt I asked this question, they said these are children of the professors, and these are the people who didn't go very well with the professors. So the professors were angry with them. So you see, so that's why, you know, these marks and patterns came up. And you are absolutely right. Pattern 2 and pattern 4 need to be investigated. They are unacceptable because the marks are not similar across the various evaluations. And pattern 1 and 3 are acceptable because marks are similar. And scientific word for similarity, as you know, is homogeneity. So acceptability depends on homogeneity. If it is homogeneous, you accept it easily. If it is heterogeneous, you don't want to accept it. How does it fit with meta-analysis? Meta-analysis is a study of studies. It's nothing but taking out average from 2 or more evaluations. And each study is evaluating and measuring some effect. If summary effect measure, which is average, is consistent with the rest of the results, means there is homogeneity, you easily accept it. If there is heterogeneity, then you want to investigate. And that's what the committee decided. So the take-home message from this story is, in a meta-analysis, combined results are easily acceptable if there is homogeneity, but you need to investigate the cause of heterogeneity if there is one. Do not combine, and if you combine, at least downgrade the quality of level of evidence. So many causes of heterogeneity in meta-analysis. 3 common sources are clinical, different population intervention, comparison or outcome, methodological, there may be different degrees of bias, and sometimes statistical, which is due to chance. How do we assess in a meta-analysis? We look at clinically what kind of population of patients, interventions and outcomes we are checking. We eyeball the results, and this is not less important. Look at the observed effects, which are called point estimates, and look at the confidence intervals, which are the lines on the sides of the point estimate. And of course, there is a statistical method, and there are 2 statistical methods. One is called I-square, which is, there is a test called Cochrane Q test, which gives you positive or negative. And here, p-value less than 0.05, even if 0.1 means considerable heterogeneity. And I-square, which quantifies consistency, which is more than 50%, is substantially heterogeneous. Now, Cochrane handbook keeps on changing the parameters, but one consistent thing is more than 50% means considerable heterogeneity, which is unacceptable. So if you look at this, I-square is only 11%, and the p-value close to that is 0.33, which is basically a degree of acceptable degree of homogeneity, and no problem in doing this meta-analysis. This is from one of our own reviews. So then you take out average, which is synthesis. Now let me ask you a very quick question. There are 200 boys and 100 girls in a class. Average weight of boys is 70 kilos and girls 40 kilos. So what is the average weight of the class? Very easy, 55, isn't it? How many of you agree 55 kilos? Yeah, 2 people agree, and others don't. So what's the correct answer? Yes? Very difficult?
60.
What is it?
60.
60. Yeah, how did you get that?
70 by 200 plus 40 by 100 and then divide by 300.
Correct. So you see, because there are 200 boys, you have to give twice the weight to 70.
Yeah.
So that's why even you can go 70 into 2, 140 plus 40, 180 by 360 kg, right? Thank you, you are very good in math, I must say. So this type of average was told to all of us in grade 6, which was called weighted average. So not simple average, weighted average. But often students say, oh, 70 plus 40, 55 kg. So what is meta-analysis? It is weighted average of the results. And here weighting is not only based on sample size, sometimes it's based on quality. Very poor quality study we remove, which means giving weight of 0. And based on sample size, but probably more important is based on number of outcome events. So if outcome events are same, then sample size may influence the weight. But if outcome events are different, it is the outcome events which determine the weight. So based on this, there is a formula which I am not going to go into, gives the weight of the studies, and you take out weighted average of the results of various studies. Then you summarize quality and quantity of evidence as well as quality and quantity of the effects. And that is nowadays increasingly being done, certainly in Cochrane, is using grade methodology. If you want to know more about this, go to www.gradeworkinggroup.org. They have a full list of publications on this, and this is being increasingly accepted by most of the organizations, and certainly all of Cochrane reviews eventually will have this grade methodology to summarize all the findings in a summary of findings table. So this is what we do for this. If you want to read in slightly let's say non-statistical language about this, then we have published a paper in JAMA very recently which tells us about how to grade as well, and you can use that to upgrade your knowledge. This time will not allow me to go into these details. One important thing in all meta-analysis is publication bias. Positive results are favored for publication, as you know. So we investigate this publication bias using what is called funnel plot. And funnel plot basically is a plot between sample size and the effect estimate. So on x-axis you have treatment effect and sample size on y-axis. If there is symmetry of all the studies, which we denote by dot, we say there is no publication bias. If there is asymmetry, there can be many explanations for that. So this is an example where you can see that there is a line which is the line of average of all the studies, and then these are studies distributed across this. Largest studies are here, smaller studies are here, which are scattered around the average. Whereas in this diagram, you find there is something missing. So maybe a whole lot of studies here, which were favoring control, which will be typically called negative studies, they were not included in this meta-analysis. So there is probability of publication bias. Here, probably there is no probability of publication bias. This we examine in all meta-analysis to make sure that we are not dealing with huge amount of publication bias. So to summarize, systematic review and meta-analysis, they of course summarize the findings till date, help generate research question, strengthen your research proposals, so it's a very key aspect of the research cycle. It's the highest level of evidence based on large randomized trials and has great potential for clinical impact. It's time consuming. I must say that some of the Cochrane reviews take years to complete, but it is often a gratifying experience. And remember the 6 S to do this. First S is state, second is search, third is select, fourth is scrutinize, fifth is synthesize, and sixth is summarize. Thank you very much.
Thank you very much for that.